I'm going to introduce our next guest now. So Shiv is one of our haematology registrars, and he's kindly agreed to present an interesting case. Yeah, let's hand over and see what everyone thinks. So thanks very much, Shiv. Who is, I must say, I'm on call with him at the moment, and he's a fantastic registrar.
Thanks, Dr. Lester. So my name is Shivir Moosai. I'm a haematology registrar in Birmingham. I work with Dr. Lester and Dr. Lowe, who are on the call. And this will be a 20-minute sort of case history, quite an interesting one, which we've had here. I apologize, my camera isn't working. So this case presentation, we'll talk about the presenting features in this case, the lab results, and then a differential diagnosis. Then we'll explore what treatment this patient had and the outcome. And we'll talk about the learning points here. And then we'll talk a bit on VITT afterwards, which I think most of you may have heard of before, given the pandemic and the vaccines which have come out. So this is the presenting complaint. So we had a 53-year-old gentleman who presented to us with acute right-sided weakness, so in both his upper and lower limb, and he had some slurred speech. Obviously, this is concerning for an acute stroke. He had a headache, which was unilateral, and some visual aura for about a month. So some symptoms preceding this acute weakness. He also had breathlessness for a week, and he was actually staying in an inpatient psychiatric unit. He was recently diagnosed with a DVT 1 month prior, sort of presenting to us, and he was on rivaroxaban, but presumably because of mental health problems, he wasn't compliant with his rivaroxaban. He also had a background of depression and obstructive sleep apnea, and these are the medications he's taking. So mirtazapine, venlafaxine, and quetiapine for his mental health, and rivaroxaban is an oral anticoagulant, which he was on for his DVT. So just to summarize, acute symptoms suggestive of a stroke, a bit of breathlessness, and he had a DVT recently, but was not taking his rivaroxaban. So on examination, his observations were all right. He was breathing fine, he had normal oxygen levels, he had no fever, his heart rate was fine, his blood pressure was normal. He had clear evidence of objective weakness in his right upper limb and right lower limb with upgoing planters. So this is suggestive of a left-sided stroke causing right-sided weakness. His left leg is where he had the DVT a month previous. It was swollen, but it wasn't tender. And otherwise, his examination was normal. Now, I don't have a nice chart here for the bloods, but I do have the actual values. So looking at his full blood count, he was slightly anemic. His HP was 103 and it was normocytic. His platelets were 109. So normal platelet count is 150 to 400. So we call this a mild thrombocytopenia. His white cell count was 2.8, which is low, and his neutrophils were actually normal, 2.00. His INR was 1.5, PTT ratio 0.9, fibrinogen 1.84, and his D-dimer was 9,500. Renal and liver function normal and CRP 85. So what this actually means, because I'm just reading out these blood tests, is that he did have an abnormal blood count. He had a normocytic anemia and his platelets were slightly low. His clotting showed that his INR was a bit elevated, but it could potentially be explained by the fact that he was on rivaroxaban, as this can sometimes cause an elevated INR. But his other coagulation studies, so his PTT ratio and fibrinogen were fine, and his D-dimer was obviously very elevated, and his CRP was up. So now we have his imaging reports. His CTPA showed bilateral PEs with some pulmonary infarction, and a CT angio, which is essentially where you put contrast through the arteries supplying the brain, so to look for a stroke, showed a left-sided anterior circulation infarct, and that was due to a thrombus in the left internal carotid artery. All right, so this chap had a DVT 1 month ago. He now presents with bilateral PEs and a thrombus in the left internal carotid artery causing a stroke. So, you know, this is his thrombosis history. He had his first dose of the Oxford AstraZeneca 50 days prior to presenting. He developed some symptoms of a DVT a couple of days later, but his Doppler didn't show any DVT. And then 3 weeks after that, it did show an extensive left proximal DVT. And you've just had a presentation from Dr. Ali Khan about the significance of proximal DVTs. And he now has a stroke and PE. So I'm sure you have a differential diagnosis in your head right now, given the title of my presentation. Is this VITT? All right, now bear in mind, this was a couple months ago, so this is around the time where we started seeing VITT. So VITT is when you've had a COVID vaccine, particularly the AstraZeneca vaccine, and you may have a rare complication where you get low platelets and a thrombotic phenotype, or was it something else? So we switched his rivaroxaban to treatment dose enoxaparin, and this was to treat the thrombus. So in his lungs, you know, his previous DVT, and he also had a new thrombus in the internal carotid artery. We didn't start him on any antiplatelets immediately. He had IVIG, which is a treatment, an initial treatment back then for VITT, and he had some steroids again for VITT, and then we did some we sent off PF4 testing. So at this point in time, the diagnosis we suspected is, you know, was VITT, and we treated him for that. He then had a blood film done about 2 days later, which showed this. I don't know if any of you know what this is, but these cells here are abnormal, very abnormal cells. They're called promyelocytes. Okay, as a hematology registrar and consultant, it's one of the conditions which it sort of drilled into you. You know, when you see this picture, you need to start treatment immediately. It's life-threatening. So this blood film was sort of made a couple days later. And the outcome of this case essentially is that this patient had a negative PF4 test or HIT test. So it wasn't in keeping with VITT. The platelet count continued to drop and the blood film showed promyelocytes. FISH, it's a molecular test which we do, and that confirms the diagnosis of APML. APML is a life-threatening acute leukemia which needs urgent treatment with chemotherapy, blood products, and a tablet called Atra. He was transferred to the hematology ward for further management, which included chemotherapy, blood products, and anticoagulation. The learning points for us on this case, you know, we manage a lot of leukemic patients and patients with APML, but it was quite tricky, you know, and we realized that we always need to look at a blood film with patients who have abnormal blood counts, you know, just to see if there's any primary hematological condition. I think we were sort of, you know, there was a bit of tunnel vision from our end, you know, in terms of the case seemed quite typical for a VITT. And everything, it was in the press, we were getting new data, so we went down that route. And the blood picture wasn't typical of something called of APML. And, you know, it was a couple of days later when we made the diagnosis, actually. So in the pandemic, there are a lot of new treatments, there are a lot of new conditions being described, and I guess it's always about, you know, keeping a broad differential. I'll just do a bit of a whistle stop through VITT. So this stands for vaccine-induced thrombosis and thrombocytopenia. It's a rare complication of the COVID-19 vaccines, particularly the Oxford AstraZeneca vaccine. You know, it's quite unusual to get it with the other vaccines, such as Pfizer. It's rare. It's a rare condition. And what you get is, it's a prothrombotic condition, and you get both venous and arterial thrombosis. So this can be, most often you tend to see cerebral venous sinus thrombosis and abdominal vein thrombosis. But you can get arterial manifestations and other venous manifestations such as DVTs and PEs. You tend to get a low platelet count and a low fibrinogen as well, and you get a significantly elevated D-dimer in the region of the thousands. Now, there's no clear risk factors for VITT other than, you know, patients who are on the, you know, younger age end of things, so those less than 40 and less than 30. But again, it still remains overall a rare condition. Having a prothrombotic condition is not a risk factor for it. Right? All cases of it in the UK are reported to the expert hematology panel, the EHP, and they're the ones who actually come up with our local UK guidelines on how to manage these cases. So there's a lot of data still coming through. So the clinical and lab features are you tend to get onset of symptoms between 5 to 30 days post-COVID vaccine, and you can get symptoms up to 42 days. There tends to be thrombosis, so that's in the name of the condition. There's thrombocytopenia of significantly elevated D-dimer. So we're not talking about a D-dimer of 300 or 400, you know, and you get a positive anti-PF4 antibodies. So this is a test which we also use for a condition called heparin-induced thrombocytopenia. The mechanism is similar. All right. This table here, so this is from the New England Journal of Medicine, but it's also in our EHP guidelines. It talks about definite, probable, possible, and unlikely cases of VITT. As you can imagine, you're not going to get this platelet for PF4 test back on the same day, you know, and you don't always have all the information to hand. But it allows you to classify, you know, the likelihood of this being VITT so you can instigate treatment. If you have a definite or probable case of VITT, they tend to be the ones who get treatment as opposed to the possible or unlikely ones. Each case is individual and is usually discussed with a hematologist. So, as I said, this is a new condition only described this year. There's a lot of treatments for VITT, and there's not much evidence, or, you know, as you could imagine, in terms of what is best. But the approach for sort of definite or probable cases is you can treat with IVIG with a dose divided over 2 days of 1 gram per kilogram. You can give steroids, so usually dexamethasone, but prednisolone as well. Anticoagulation, so you can use a DOAC, fondaparinux, argatroban, and danaparoid, and we tend to not give any heparin drugs because of the association of heparin with HIT, you know, and if we're already suspecting something like VITT, which is of a similar mechanism, we tend to avoid low molecular weight heparin or unfractionated heparin. Plasma exchange is also being used, and I believe that's what we use locally for very severe cases or resistant cases. So a couple of days of plasma exchange, aiming for a normal platelet count. For CVST, so cerebral venous sinus thrombosis, early use of plasma exchange, because these tend to be very unwell patients and they do have a significant mortality rate attached to them. We use plasma exchange, high dose steroids, and we also ask the neurosurgeons if there's anything, or the interventional radiologists if there's anything that can be done for them. You tend to get a low fibrinogen with these patients, so you aim for a fibrinogen count above 1.5, and you use cryoprecipitate or fibrinogen concentrate for this. All right. Now, some patients will have had the vaccine, they will not have thrombosis, but they may have other features of it on their blood work. So low platelets, very high D-dimer. They may have symptoms of thrombosis, but nothing proven. And you don't tend to treat that as VITT. What you tend to do is give prophylaxis, but with something which is not a heparin type drug. And then rituximab can also be used. But again, the evidence for this, well, there's no evidence of its efficacy, but the idea is you're trying to knock out your own B cells, which make antibodies, which are implicated in this condition. So this here is just a flow chart from the expert hematology panel. So it probably is the easiest thing for people to remember to keep on their phones as the flow chart, as to, you know, how to classify cases and how to manage them. All right, and what to do if it's a definite or probable case versus possible or unlikely. As a junior doctor, you're probably never going to be managing this on your own. Even as a hematology registrar, we don't manage this on our own. This will usually be a case discussed with hematology consultants. All right, so again, this is a very whistle-stop sort of presentation and summary of VITT. Are there any questions?
Thanks, Shiv. That's excellent. So I think, I mean, in some ways, it may be that VITT will be in the history books in the UK. we've not seen a case for a long time now. But I think there is a really key message here, and that is bias. I don't know if it's called anchoring bias here, but this is about when you're looking for something, and in this case VITT was in the news and everyone was looking for it. Everyone who came into hospital with a coagulopathy and low platelets was being labeled as VITT, when people were forgetting that you should always start from first principles. And there were numerous cases where patients with disseminated cancer, and in this case a leukemia, were initially falsely labeled because of this anchoring bias, because everyone was looking for it. So I think it is a really key message that you should always approach each new case afresh. There is a question, and neither of us were directly involved in this case, I don't think, but there is a question about the case, which is, why did we use heparin in this case? I mean, I don't know if you're aware of this, but I can make a comment if you're not, Shiv.
From my understanding, I believe the fact that the patient had, so they were thought to be on rivaroxaban, even though they weren't that compliant. They then had subsequent thrombosis, so you can call it breakthrough thrombosis. So the idea was to put the patient on enoxaparin. And the other thing is he needed multiple sorts of investigations and procedures being, done. So it's thought that that would be an easier way to manage the patient. One was rivaroxaban not working and he had breakthrough thrombosis. The other one was to do around procedures and planning. But I don't know what you think, Dr. Lester.
In the context of the fact that the VITT had been considered a possible diagnosis,